Our topic now brings us into peptic ulcer disease. A peptic ulcer disease, you divide this into that disease or erosion that's taking place in the stomach versus that type of erosion that might be taking place in the duodenum. By far, in the U.S., the most common type of peptic ulcer disease would be the type that's taking place in the duodenum. However, for learning purposes, we need to make sure that we cover both sets of peptic ulcer disease. And then, importantly, we will go through the symptoms of your patient so that you're able to distinguish one from the other. Mechanism of injury. If there's direct mucosal damage due to toxins, ethanol, NSAIDs, bile, or H. pylori. Now, for the most part, you can think of peptic ulcer disease taking place in the stomach as really not due to increased acid production. Remember that the stomach is extremely effective with protecting the lining of the stomach from the acid. And due to all that bicarb, you have prostaglandins and such, so therefore protecting the stomach from all that acid. However, if the lining of the stomach has been compromised where it could take place due to, let's say, NSAIDs, which is then inhibiting your COX pathway, then you might then inhibit the formation of the prostaglandin necessary to properly protect or contribute to the protection of the stomach. Or if there's actual chemical damage taking place to the lining of the stomach due to bile that might then regurgitate back into the stomach. Remember, bile is being released or secreted from your gallbladder into the second part of the duodenum. So therefore, there must be some kind of method by which the bile is retrograde flow back in the stomach, causing damage. H. pylori in the stomach would be residing where? In the antrum of the stomach. And from henceforth, whenever you deal with H. pylori, you should be thinking either the distal end of the stomach or the first part of the duodenum as being its place of residence. In the stomach, the H. pylori, if you remember from micro, then has an enzyme called urease. Therefore, it'll take the urea and it will create a force field for itself. That force field that H. pylori then creates in the antrum of the stomach is then made up of ammonia. Amazing, isn't it? At some point in time, it could then burrow into the lining of the stomach and so therefore weakening the lining, resulting in peptic ulcer disease. H. pylori, bile, NSAIDs, alcohol. Prostaglandin inhibition, like we just said, with NSAIDs or steroids, even with pathologies such as Cushing, in which you would have excess cortisol, hypercortisolism, is then knocking out your phospholipase A2. You don't have the necessary prostaglandin to protect the lining of the stomach as such against the acid. Increased acid production could be a cause, but more importantly, the most important pathogenesis for peptic ulcer disease of the stomach would be damage to the lining. Whereas if it is pathogenesis for peptic ulcer disease of the duodenum, then in fact there would be increased acid. For example, if you do Zollinger-Ellison syndrome, and with the gastrinoma, with all that acid which is then coming out like a huge wave out of the stomach and into the duodenum, there is no way that the duodenum can properly protect itself against all that acid. Mucosal ischemia is always a possibility. Whenever there is infarction that's taking place, then at some point in time you might then be hurting or injuring lining of the stomach. Peptic ulcer disease. If it is in the stomach, the patient here is going to be complaining of epigastric pain. However, this time around, with peptic ulcer disease in the stomach, you would not find, and the patient would not be complaining of pain that's radiating to the back. Is that clear? On your step and on your wards, if the pain is radiating to the back, then this gives you the high suspicion and differential of pancreatic damage. However, if it's not, then you're thinking about peptic ulcer disease. Also, with this erosion that's taking place, remember, you have not perforated. Ulceration means ulceration. It's a clean punched out lesion in the stomach. And a clean punched out lesion here with bleeding taking place may result in hematemesis. With all this blood that's now being released, either from the stomach or maybe perhaps the duodenum, you can only imagine that, as I told you earlier, that the stool has an opportunity to completely saturate itself with blood. So therefore, by the time it's evacuated, here the stool, in fact, is going to look black and tarry. Hematemesis, hematochezia, iron deficiency, anemia, all of these, well, all part of bleeding. Next, if there's perforation that's taking place, especially of the duodenal type of peptic ulcer disease, it'll then perforate and then it will then affect different organs or blood vessels. If it is peptic ulcer disease of the stomach, which is usually found in the lesser antrum of the stomach, and if it is to perforate, then you are then going to, or the perforation is going to affect the left gastric artery. Whereas if the perforation takes place down in the duodenum, then the perforation then causes damage to the gastroduodenal artery. Gastric outlet obstruction due to peripyloric scar formation is an important complication. At some point in time, when there's enough damage that's taking place, any type of damage, at some point, the body wishes to respond with the repair process. This repair process that you're looking for, at some point, with fibrosis taking place, may actually then cause gastric outlet problems because of the, more or less, think of it as being a stricture formation or scar formation, and therefore decreasing the emptying of the stomach. Gastric ulcers may be malignant, while duodenal ulcers are basically never. Once again, peptic ulcer disease, keep in mind that if it's the stomach, you should be monitoring or should be thinking, there's a possibility of a primary gastric cancer developing. In duodenal, almost never. On the left, peptic ulcer disease is in the duodenum. You'll notice that you have a clean punched out lesion. Whereas a gastric ulcer, you also have a clean punched out lesion. Endoscopy, esophageal gastroduodenoscopy, would be your best measure or best method of diagnosis. With this ulceration, at some point, remember, keep your ulceration and perforation completely separate. Management of peptic ulcer disease. Antacids. Because of the burning sensation that's taking place, magnesium and albumin cause long-term toxicity. Be careful with antacids, magnesium and aluminum. Milk alkali syndrome due to prolonged use of calcium is something that you want to keep in mind with antacids. Once again, milk alkali syndrome due to prolonged use of calcium.
PPIs are first-line treatment for a PUD, and they are also used in combination with antibiotics to treat H. pylori.
Sucralfate. It stimulates endogenous prostaglandin production so that it helps to then protect the lining of the stomach. Avoiding renal insufficiency, and that's a big deal. So the drugs that I've given here for management, I've given you as to what it does objectively, and then things that you want to keep in mind as side effects, because these patients will be on these drugs for quite a bit of time.
Peptic ulcer disease. We have two types. The duration of therapy, if it's duodenal ulcer being the most common type of presentation in the U.S., 4 to 6 weeks of duration. If it's gastric ulcer, then it's 6 to 8 weeks with repeated esophageal gastroduodenoscopy to document the healing. The management, remember, H. pylori highly associated with both of these issues. So therefore, the importance of eradicating H. pylori cannot be understated, responsible for developing lymphomas, perhaps, and maybe even our intestinal type of gastric primary adenocarcinoma. Now we have two types of treatment, so you want to either think quadruple, bismuth, and the quadruple therapy would include bismuth, metronidazole, tetracycline, and proton pump inhibitor. Or you could have clarithromycin-based triple therapy, which would then consist of amoxicillin, clarithromycin, and your PPI.
NSAID-associated peptic ulcer disease. Your patient taking, let's say, NSAIDs for osteoarthritis, or in general, just inflammation of the joints. Been taking this over decades, and with NSAIDs, as we mentioned earlier, if the prostaglandins are then lost within the stomach, the lining of the stomach, in fact, now becomes vulnerable to the acid abuse, and so therefore may bring about erosion of the lining. resulting in peptic ulcer disease of the stomach. The first case that you're going to find with peptic ulcer disease of the stomach with long-term use, you consider this to be acute. It's not like you take one aspirin or you take one ibuprofen and then all of a sudden the patient develops peptic ulcer disease. That makes no sense. You have to be taking these drugs over a long period of time. Also, keep in mind, though, if NSAIDs have been taken over a long period of time, that in the kidney, with prostaglandins responsible for keeping the afferent arteriole open, if NSAIDs are taken, you take out the prostaglandin, you're at risk of vasoconstricting the afferent, and over a long period of time here as well, you're worried about chronic kidney injury. Is that clear? Two major organ systems that are extremely vulnerable to attack with NSAID use, and really, because of the easy accessibility of these drugs by the patient over the counter, you have to properly educate your patient because they're going to be popping pills all of the time whenever they feel pain, and I'm talking popping pills excessively for a long period of time, and they may or may not even tell you, right? Increased risk of bleeding with low dose and high dose aspirin, through the increased risk of dose dependencies, which we're worried about. Exactly what I was saying. The patients are in pain. They might be taking aspirin, and they might be increasing the dosage without you ever knowing. It's important that you establish in your practice excellent rapport with your patients so that they're being transparent between you and your patient. Enteric coating does not reduce the risk of bleeding. Do not allow the advertisements and the commercials to fool you. High rate of mortality for NSAID associated with GI bleeding. Who's your patient with NSAID associated peptic ulcer disease, greater than 70, higher dose of NSAIDs, often associated with H. pylori and concomitant corticosteroids? Remember, please, with NSAIDs, they might very well be in pain, and if they are, they're probably taking prednisone as well. My goodness, the combination of NSAIDs and corticosteroids definitely compromises the production of your prostaglandin, therefore increases the risk of peptic ulcer disease further. Also, anticoagulants and prior history of peptic ulcer disease. NSAIDs, what does it do? Inhibits your prostaglandin, management, PPI, and removed NSAIDs. At some point in time, if peptic ulcer disease has kicked in, remove the offending agent. Educate your patient properly. And PPIs. Always feature H. pylori, highly indicated, gastric or duodenal. H. pylori, for the most part, you assume is present. Prophylaxis, misoprostol, a prostaglandin. It's an prostaglandin E derivative and combats the effects of NSAIDs. Diarrhea is a dose-limiting side effect, however, and absolutely contraindicated in pregnancy. Prophylaxis, PPI, superior to H2 blockers we've talked about when it comes to acid control. COX-2 inhibitors might be a possible alternative. Lacks cardiovascular protective effect. And GI protective effect lost with concomitantly baby aspirin use. So COX-2 inhibitors, you've heard of celecoxib, so on and so forth, might be alternatives that you're looking for when dealing with NSAID-associated peptic ulcer disease.